Hi, everyone. I'm Angela Riss-Jackson. I'm the Chief Operating Officer at UCSF Bakar Computational Health Sciences Institute and part of the planning committee who helped to organize this workshop. First of all, I want to say that I know there's a lot of people on Zoom. We're seeing a lot of questions, and I've also seen a lot of hands go up in the room, and I want you to know that we are going to do our best with the time we have to address as many questions as we can, but we are also attempting to capture all of your thoughts, and this is one of our methods for doing that. So throughout the day, I'm going to guide you through a number of polls. This is audience participation polls to both get your opinions and also, again, capture those thoughts that you would like to share. And I will also commit to sharing this information back to all of the participants. We're going to capture it all in some kind of report, and it will be shared with both you and with our leadership and potentially beyond. So I would like to invite everybody now to take out your devices. It's totally acceptable. Go to slido.com or use this QR code, and you'll see a place to enter. Yes, I'm going to activate it right now. So, oh, you're so eager. I just want to give everybody a moment to do this. So type in the hashtag AJ Workshop at slido.com, and I'm going to activate our practice poll right now. So our very first poll just is a word cloud. Please just type in one word. You can do multiple entries, but one word at a time. Please just type in whatever word comes to your mind when you hear the term algorithm. I'll give everybody a moment to do this. Okay. Lots of math. German. Okay. So we're seeing a lot of consensus here, I think, but also a lot of diverse perspectives. Again, we're all experts here. All right. I see 5 people typing. I'm going to give you about 30 more seconds to complete your typing. And then I'm going to close this out and I'll start the real survey. This is just a practice, but you guys are doing great. Okay, 2, 1. Finish that typing. 2. Oh gosh. All right. Oh, it just keeps going up. All right. I gotta close you out here. All right. So our first set of polls here, the real ones, is a self-identification poll. So we want to understand the perspectives in this room today. So I want you to first answer your relationship to UCSF. And the second question here will be how you see yourself relating to algorithms. This becomes important for us as you see the next set of questions after every panel, because we do want to understand the priorities and whether priorities change depending on the different perspective groups that are represented here. I was told by somebody online, stakeholder is not the best term to use. So I'm going to try and not use that phrase. Okay. Let's look at our next one here. Good. I was hoping to see a vast majority of you say I am subject to the use of algorithms. Okay. So great. I really think this is an important one, so I'm going to let everybody finish. I'm going to wait until I see this one finished, and then I'll move on to the next poll, which is the actual opinion poll for panel 1. Okay, great. So let's move on to panel 1 questions. This one, I'm not going to show the results. You can see them as soon as you submit your answers. We don't want to introduce bias into these results. Yeah. Yes, so it's slido.com and you enter the hashtag AJ workshop to join this poll. And you can leave this, by the way, leave this page up on your device because we'll be returning to it. You don't need to enter that again. I should also say we've been sitting and watching people talk for a little while. So now is a good time to get up and stretch your legs if you feel the need to do that. Might be a good idea. We are going to start the next panel here in a little less than 10 minutes. So take your time, please, answering this question, though. Got about 5 minutes. And just to clarify, that open text box, that is one way that you can submit your comments, questions, things that have not been discussed yet. You can submit them there. All right, I see some people are still responding. I'm gonna give it about another minute and then I'll show the results up here. We can just have a quick check.
Yeah, I know.
Okay, I don't see any more active. Oh, okay, I lied. All right, I'm gonna go ahead and show. I'm gonna show the results. In case anyone's curious. Looks like our #1 top priority here, accessible reports on how the outcomes are evaluated and how they perform for different at-risk populations. All right, let's look at the next question. It's like we've got a consensus here, mostly agree or strongly agree that individuals should see the predictions of the algorithms when applied to their own data. Again, strongly, oh, okay, about half strongly, but the rest. Okay, I'm actually interested to see this. Disagree and neither agree. Okay. So this is about opting out. Very contentious, this one. All right, I think we're good with the polling for panel 1. We will see another one of these right after panel 2 Q&A. So please keep this open. I'm going to close out this poll and invite the moderator for panel 2.
So greetings, everyone. My name is Tung Nguyen. I am a professor of medicine here at UCSF, and I am also a community-based participatory and health equity researcher, a principal investigator of the UCSF Clinical and Translational Sciences Institute, and the UCSF Associate Vice Chancellor for Research Inclusion, Diversity, Equity, and Anti-Racism. And it's my great pleasure to moderate this panel titled Engage Patients and Communities in All Phases of the Healthcare Algorithm Lifecycle and Earn Trustworthiness. I'll take a moment to talk about an anti-racism and anti-oppression approach. Last night at dinner, there was a guy sitting next to me who had a huge A on his shirt, and at the top in smaller text it says anti, and the bottom it says everything. We're not anti-everything, but in all the talk about AI becoming our new tech overlords, I keep thinking about a saying from decades ago, meet the new boss, same as the old boss. In a system designed to create inequities, racism, and oppression like ours, innovation will likely make things the same or worse unless we question the system while trying to make the work within it with the explicit goal of ensuring equity and justice. The best way to question the system and to fix it is to widen the circle of inquirers and interventionists. That's what community engagement tries to do, and we're going to try to explore this in this panel. Our 3 presenters are Jessica Newman, who is the Director of AI Security at UC Berkeley, Center for Long-Term Cybersecurity. She is the co-director of the UC Berkeley AI Policy Hub and co-director of the Algorithmic Fairness and Opacity Group. She conducts research on the social, ethical, and security implications of AI and on policy and governance practices that can support safe, equitable, and trustworthy AI. She advises government and industry partners and teach trainees, and has served as a member on working groups for major national and international groups and organizations. Our second presenter is Dr. Monica McLemore, who is a tenured professor in the Child, Family, and Population Health Department and the interim director of the Manning Price Spratlin Center for Anti-Racism and Equity in the University of Washington School of Nursing. Prior to her arrival at UW, she was a professor here. She retired from clinical practice as a public health and staff nurse after a 28-year clinical nursing career. So I guess you're in like your third career now. Is that what you're? Okay. Her research is focused on understanding reproductive health and justice. Her work has been cited in 5 amicus briefs to the Supreme Court and 3 National Academy reports, and she is the editor-in-chief of the journal Health Equity. And last but not least, Mohana Ravindranath is a health tech reporter with STAT covering the Bay Area. She's especially interested in health equity as it relates to digital health. Before STAT, Mohana covered health tech for Political and Business Insider. She was previously a tech and small business reporter for NextGov and the Washington Post. I'm going to ask Jessica to come up.
All right. Hello, everyone. And thank you so much to the organizers for this fantastic workshop. It's really a pleasure to be here with you all. So part of our panel was around this question of earning trust. So I wanted to think about this term, trustworthy AI, a little bit more and think about how we can work towards that goal in relation to how people access and receive healthcare and how they can meaningfully engage in the design and development of AI as it relates to their healthcare. So I was interested to see that trustworthy AI was not in the glossary that we got when we walked in here. So maybe that's telling about the challenges with this term. So first, where does the term trustworthy AI come from? I think it's important to remember that it builds upon longer histories of trust in computing, cyberspace, and automation. But in those contexts, it tends to mean that a system performs according to designed behavior under any set of conditions, and includes establishing a chain of trust developed by validating each component of hardware and software from the bottom up. So even in traditional computer security, these conditions are difficult to meet. So many security professionals actually advocate for a model of zero trust, meaning that because breaches are so common, we should in fact never trust blindly, but always verify. Moreover, the meaning of trustworthy AI and potential approaches to attain it are contested. So there is no universal definition of trustworthiness. There are different cultural and political understandings of trust. The term is also often used too vaguely to be helpful, where it's not clear who is supposed to trust in what or whom. But nonetheless, the phrase trustworthy AI in particular is now commonly used in multi-stakeholder forums, beginning perhaps most famously with the 2019 publication of a document called Ethics Guidelines for Trustworthy AI. This was developed by the High-Level Expert Group on Artificial Intelligence, an independent body set up by the European Commission. The authors at the time identified trustworthy AI as their foundational ambition, and they wrote that in a context of rapid technological change, trust remains the bedrock of societies, communities, economies, and sustainable development. They define trustworthy AI as being lawful, ethical, and robust, both from a technical and social perspective. Since then, the EU, the OECD, and the United States have all reiterated the call for trustworthy AI. The OECD has stated that trustworthy AI refers to AI systems that embody all of the OECD AI principles. The National Institute of Standards and Technology, or NIST, in the United States has taken a similar approach. It defines trustworthy AI as embodying 7 characteristics of trustworthiness, which you can see in the image on the top left of the slide here. So all of these characteristics of trustworthiness are explored in detail in the NIST AI Risk Management Framework, or AI RMF, that was released in January this year. The AI RMF also describes the AI lifecycle, and you can see that in the outer ring of this image on the right here. So at the UC Berkeley Center for Long-Term Cybersecurity, we published an additional complementary resource to go along with the NIST AI RMF, which is called A Taxonomy of Trustworthiness for Artificial Intelligence. And the paper further expands on these 7 characteristics of trustworthiness and identifies 150 properties of trustworthiness, each of which is designated to a particular part of the AI lifecycle, where it is especially critical, and is accompanied by a set of questions to consider. Each property is also linked back to specific subcategories of the NIST AI RMF, so that readers know exactly where to go to find additional helpful resources. So in the paper, we offer a few interventions about the notion of trustworthiness in AI, and I think this follows nicely from some of the comments we heard this morning from Ida Sim and Peter Norvig, among others. So we argue that it's not just about a particular technical system, but also about the actors and the processes that develop, deploy, and monitor that system. We also argue that self-assessment of trustworthiness is flawed, and that independent auditing, technical standards, and federal regulation are all critical. And that trustworthy AI is an aspiration and ongoing process, rather than a precise descriptive quality or easily attainable goal. Finally, we clarify that meaningful trustworthiness for AI may ultimately be unwarranted or unattainable. So what does this mean in the context of healthcare and precision medicine? In many ways, AI and precision medicine have grown up together over the last decade, which I think we've heard a bit about today. Advances in machine learning have propelled forward a lot of the promises of precision medicine, offering the ability to gain actionable insights from enormous amounts of biological data. But despite the promises of more tailored and accurate healthcare, we know that this promise has largely not been realized for the many. In the US, we don't have universal healthcare, and adding additional high-tech, high-cost solutions typically means they will only serve those patients willing to pay the most. And of course, the integration of AI into precision medicine amplifies these problems in both technical and structural reasons. So part of the problem is that AI models trained on historical data sets simply cover up and then amplify persistent racial, gender, socioeconomic, and other biases and discrimination that have plagued access and quality of healthcare for generations. There are also other reasons to be skeptical about placing trust in AI systems in high-stakes settings such as healthcare. Machine learning models in general and large language models in particular have novel security vulnerabilities and are susceptible to adversarial attacks. So this can be dangerous in a healthcare setting where bad actors can try to exploit these vulnerabilities to gain access to sensitive information or even cause a model to output incorrect information and directly impact somebody's health and safety. But it's not just bad data and insecure models that we have to worry about. The fact that many AI technologies are developed by a small number of companies that are often insufficiently transparent about how their models were trained and developed and what their limitations are, means that in most cases, patients and impacted communities do not even know how and when AI systems are being used, let alone get the opportunity to contribute to decisions about appropriate design and use. So we need much more robust accountability and liability regimes to ensure that AI companies are sharing information and engaging with communities. But we know that better engagement is called out repeatedly in the frameworks for trustworthy AI. In the NIST AI Risk Management Framework, the category Govern 5 is all about establishing processes for robust engagement with relevant AI actors and integrating feedback about risks, system design, and implementation. Subcategory Measure 3.3 also calls for feedback processes for end users and impacted communities to be able to report problems and appeal system outcomes. The White House Blueprint for an AI Bill of Rights is another important tool for promoting trustworthy AI. And you can see in the image on the bottom left of the slide here, the 5 principles and practices that it outlines. And what an incredible honor to be here with Alondra Nelson, without whom this incredible document would not exist. So the AI Bill of Rights specifically calls out healthcare as a domain in which it should be applied. Like the NIST AI RMF, the AI Bill of Rights similarly focuses on engaging with diverse communities, stakeholders, and domain experts in order to identify potential impacts. It also specifies that you should always know that an automated system is being used and understand how and why it contributes to outcomes that impact you. The blueprint also stands out because it specifies that people should be able to opt out and have a human alternative where appropriate, as well as a remedy for any problems that have been caused. And then just last week, the White House released an executive order on the safe, secure, and trustworthy development and use of artificial intelligence. So the EO calls for community engagement and includes numerous recommendations specifically for healthcare. Part of the EO focus on healthcare is related pretty squarely to promoting innovation. For example, in section 5.2, it calls on the Secretary of the US Department of Health and Human Services, or HHS, to collaborate with the private sector to advance AI-enabled tools that develop personalized immune response profiles for patients. But the EO also recognizes that ensuring safe and responsible deployment and use of AI in healthcare is critical. It calls for the establishment of an HHS AI task force to develop a strategic plan on responsible deployment and use of AI in health and human services, including incorporating equity principles, as well as safety, privacy, and security standards. I want to mention that HHS does already have a pretty detailed trustworthy AI playbook as well, and this is public. It's focused on how leaders within the department can apply principles of trustworthy AI throughout the AI lifecycle, so I recommend looking at that. But the EO also calls for an AI assurance policy to evaluate the performance of AI healthcare tools, and it calls for an AI safety program to identify and track clinical errors resulting from AI deployed in healthcare settings. It also gives HHS 1 year to develop a strategy for regulating the use of AI in drug development processes. So I think these are really promising developments. It was an exciting week last week. The EO recognizes the particularly acute need for trustworthy AI in healthcare. But we have to remember that implementation of the EO will take some time. So in the meantime, what are some practical and policy solutions that healthcare systems can take right now? The NIST AI RMF and the AI Bill of Rights offer a solid foundation. They identify those key elements of AI systems design and development to assess and document, and they provide helpful guidance about how to engage with patients and communities at all phases of the healthcare algorithm lifecycle. I also want to draw people's attention to a report developed by the University of California Presidential Working Group on AI. This provided recommendations to guide the University of California's AI strategy. One of the AI use cases that we looked at was the use of AI in UC Health. And we made 7 recommendations, including making sure to get input and feedback on specific AI projects during the design phase, as well as improving communication techniques and interfaces to help make AI systems understandable to diverse patient communities. So hopefully I've convinced you that there are some helpful frameworks out there for helping to earn trust throughout the AI lifecycle. In the meantime, and without significant external intervention and regulation, we might do well to remember the zero trust model and not ask anyone to blindly trust, but rather to always verify. So with that, I'll conclude my initial remarks. Thank you so much, and I look forward to the questions you have in the panel discussion. I'll now pass it over to Monica McLemore, who is a professor in the Department of Child, Family, and Population Health, Nursing, as well as the Interim Associate Dean for Diversity, Equity, and Inclusion at the University of Washington. Thanks again.
Can we give a shout out to the organizers, because I just think this has been really incredible. My head is blowing up. I wrote comments, and I'm going to try to stick to the script, but thank you very much to the organizers. It's been... I'm Monica McLemore. I use she and her pronouns. You have my affirmative consent to tweet, Instagram, Live, Mastodon, Facebook post, do whatever social media tools you're going to use, because I'm going to post these comments to my Medium channel later on today. Ida, Keith, Ben, Tung, Chancellor Hallgood. I'm emotional. I've been back and forth to Oakland every month since I moved from the Bay Area, but this is my first time back on campus in any official capacity. So thank you very much. It's been good to be here. To the people on Zoom, shout out to y'all. I know a lot of times y'all get ignored, but I see you. Dr. Nelson, thank you for being so brilliant and vanguard in your work. I'm a huge fangirl. Before I begin my formal comments addressing the questions that were put before us, I'd like to trouble this discussion. I don't know if anybody else's head is blowing up, but mine is. And give you some provocative ideas to consider from a reproductive justice, community engaged, and health equity perspective. Reproductive justice is a human rights framework that posits that reproduction, whether it's the propagation of our species to the reproduction of ideas and opportunities, all have to be grounded in autonomy and existential freedom from harm or violence from any individual, any government, any state. I'm now going to start to add algorithms and synthetic manifestations of social problems to that list. Let me give you some definitions. Community engagement includes community-driven, community co-designed, and community-led work. Health equity, defined by Dr. Kamara Jones, is the assurance of the conditions of optimal health for all people, which according to Dr. Ryan Pettaway, a public health researcher, health equity will not be achieved, but it will be experienced. Why would I begin like this? Well, because the fundamental question I wrestle with is the notion that the health professions, we pride ourselves on relationship-based care. In fact, the caring professions, and nursing in particular, my discipline, is grounded in the work of sanctity and the sacredness of witnessing the transitions from illness to wellness, from symptom recognition to diagnosis, to treatment, from life to death. As a laboratory trained scientist, I always wrestle with this one. In our spiral towards the molecular, and I will now add the artificial, what are we losing in our education, research, and training programs for clinical learners? So it's in this context, let me examine what trustworthy AI could, would, and should look like when our ability to get caring from each other is so wrong currently. Health services provision, we have bias, racism, mistreatment, these things are rampant. And I would argue, particularly because our workplaces are inhumane. I've organized my comments around three broad themes. Number one, countering the obvious. Number two, grappling with fairness. And number three, something I've been testing out on Twitter, tools need rules. We've already mentioned the executive order. I'm not going to reiterate that, but I do want to trouble this discussion. I mean, y'all asked me to speak because I'm provocative, right? Nowhere in the list do I hear the assurance of a basic minimum income for people who are going to be displaced by AI, or bold consumer protections like those passed in Washington State in My Body, My Data, signed into law by Governor Inslee and authored by my friends, colleagues, and collaborators led by John Pincus at the Washington Privacy Organizers and Indivisibles. I hear no assurance of the discontinuation of the racial profiling in medical records or the continued harmful effect of reporting scientific findings or of health disparities without capturing assets or resilience. I remain frustrated that the so-called care economy or care work is not valued in and of itself as a goal and a manifestation of our purpose on this earth. So as many of my nursing colleagues from the Nursing Mutual Aid Collective, and specifically Dr. Ray Walker and Dr. M. Blaze, who have taught me and were original thought leaders in planning out this conference, I hear the same retrofitting of our tepid solutions we're currently using to address long-term social problems unique to our species. And I would like to remind y'all, immortality is not an option, and that existentially, all we really want is a dignified life and a dignified death. This is why I'm also skeptical of starting AI processes at problem formation. Because if immortality is not an option for our species, we're not all defining the problem the same way. Grappling with fairness. I spent this past weekend in Philadelphia with friends and collaborators, including the brilliant Dr. L. Lett, a Black trans woman who is an MD candidate and a PhD graduate at Penn Medicine. And she has made the following points in a published piece in Nature Machine Intelligence. I will quote her work directly because early career mentees are brilliant and their work deserves to be amplified. And I will not represent her words as mine. For your consideration, the current status quo of researchers defining prediction tasks without community input systematically continues to exclude the perspectives of marginalized groups. Decreased access to and frequency of healthcare leads to underrepresentation and increased missingness in training data. All you have to do is look at the enrollment of, or the lack of enrollment of Black people in clinical trials to understand this point. Therefore, we need to reimagine data set construction. I haven't heard a lot of dreaming today, and so I'm hoping that we can talk about that to prospectively address our known representation deficits. Specifically, we need to advocate for purposive recruitment, data collection, and pooling to increase the representation of marginalized groups in validation data sets. One of our patient advocates said this so brilliantly earlier that if you have too many comorbidities, they're not even going to be included in some of these algorithms. Tools need rules. Use of machine learning and AI are perfect exemplars of why a one-size-fits-all solution will not be helpful when constructing rules for tools. As a teacher who now has undergrads, I have listened to students, particularly those who speak multiple languages, in terms of how useful AI is in assisting them to keep the nuances of language technically accurate, and as an equalizing tool that allows developing writers to not start with a blank slate. As a prolific scholar and the editor-in-chief of Health Equity, this resonated deeply with me. My head is so full of ideas that I need to use a brain dump and dictation functions. This has always allowed me to have the freedom to journal and to return to these rants and then to outline them, save that content for a parking lot to be used later, and to develop pieces for science, teaching, and the public. I hope to push us to really consider lessons we clearly did not learn specific to social media and other public digital fora of communication. You know, I constantly say if Nazis, bots, and trolls are the only people who are using social media, communicating directly with the public that we serve, then we as a scientific community cannot be mad when misinformation and disinformation runs rampant, particularly when the science that we publish sits behind paid firewalls, or we don't even know how the algorithms that we're using work. This is why public data repositories, algorithmic mechanisms, multiple community advisory boards with conversations like this is so crucial. I've learned in my own work the value of crowdsourcing work and investing in community-generated big data. It returned me to my love of discovery. So in closing, I hope we'll wrestle with the notions of what constitutes trustworthiness in AI in the context of the care professions, that we consider the facets of fairness, particularly when healthcare reparations and other restorative actions have not been taken. And finally, what rules do these tools need for who, by whom, and when? I look forward to our continued conversations in these important discussions. And I have purposefully used the word hope throughout my talk, and I'll end with a quote from the architect from The Matrix. Quote, hope, it is the quintessential human delusion, simultaneously the source of your greatest strength and the source of your greatest weakness. I will now pass it off to Mohana Ravindranath, see, I practiced too, Ravindranath from STAT. Thank you.
Awesome. Thank you so much for including me in this. Journalists are pretty frequently asked to cover these kinds of sessions, but very rarely asked to participate. So I think it's a really great chance for us to sort of learn what we can give to the community and sort of how we can highlight some of these issues that have come up in previous discussions and just sort of elevate the voices of patients and communities that are historically left out. So I thought I'd do two things with my time here. First, I wanted to tell you sort of what I've found in my efforts to include patients and underserved communities in my reporting. And then I want to tell you what I've heard from the people that actually work in this field more directly. I've talked to a lot of sort of community health workers and people that work in trying to engage patients and underserved communities on things like precision medicine, not limited to, but things that include precision medicine. And I want to tell you what they hope that you know, because some of them are not in the room. So first, a little background. I report for a publication called STAT, which is part of the Boston Globe Group, and we focus on health and medicine news. And a lot of our readers tend to be sort of health system executives and doctors, not as much patients. And it's part of my mission as a reporter to include patients and community voices in my reporting. So last year, I got a grant through USC to do more community engagement reporting, which I thought would be really great, but it was a lot more challenging than I thought it would be. I'll tell you, it was not super successful. And one of the things I learned in that is that intention is not enough. And you can tell yourself, I'm going to involve patients and I'm going to involve communities in each of my stories. It takes a lot longer to reach those kinds of underserved groups than it does to reach other kinds of sources. You know, patients, maybe I would find a patient through a health system or something like this, and their phone number would have changed, or they would agree to a time, but when I actually called them, they wouldn't be there, and then I could never find them again. You know, sometimes they wouldn't be able to take time off work. Sometimes health systems had no incentive to find patients like that for me, and they would blame HIPAA often, even though I knew that wasn't the actual reason. So, you know, another theme that emerged out of this effort is just because it's my priority to include their voices does not mean it's their priority to give their time and their opinions to me, especially for a publication that doesn't necessarily reach them. And, you know, that's part of my effort as a journalist, is to sort of bring them into the fold. But just because I'm trying to do it, and just because I'm trying to tell them, like, this is something you should be doing, I'm giving you this platform, why don't you want it, doesn't mean that they do. So what I realized is that actually meaningfully changing how we include these patients and underserved communities in our coverage requires a much longer arc of building trust and you know, digging the well before we actually need these patients for these stories, right? So it means actually going out into the community and building relationships with the people who are already there, and going out and visiting people before I need to bug them for quotes, right? And making sure that I'm not bugging them on a deadline that's for tomorrow when they need like a couple of weeks notice, things like this. You know, finding the right community member is really important, but it's also not necessarily the community member's job to do this for me, right? And so I can bug them and say, I'm giving you this amazing platform to get your patients on there, but maybe the community organization has their own system for involving for getting patients' voices and involving the community. So it's just important to recognize that just having the intention and just having the plan is really not enough, and it takes a lot more thoughtful planning to be able to do this. So I want to turn now to what I've heard from community health workers and the people that actually do go out into the field. And something that I learned after talking to them, especially specifically for this workshop, is that there is a much bigger body of work that exists already on this topic. I don't need to reinvent the wheel here. There is like, you know, community-based participatory research frameworks, things like this. There are each of the community organizations I spoke to has their own method and their own language for reaching the patients and communities that they talk to. And I thought it was interesting to mention this because I often talk to startups who are building this really incredible, what they say is really incredible technology, and they're not as focused, or they justify not being as focused on underserved groups because they say it's hard to reach those groups. And what I am hoping that they'll take away from this kind of conversation is that you can reach them, you just need to spend time developing a sort of more tailored approach. So one of the things that I took away from one of my conversations with Dr. Kareem Watson from all of us is that precision medicine needs precision engagement. And I think we walk into these kinds of conversations with underserved patients and communities, assuming that we know how they're going to approach technology, or we know how they want to be asked. We assume that we know what kinds of questions they want to hear, or you know, example is some people really like the word empower. Other people really don't like the word empower because it can be condescending. Who are you to give me data to empower me? I already have the power, right? And some other people find that compelling. And so we have to sort of be cognizant of how these mechanisms like language or the medium by which we contact people can change sort of the message. It's something I like to think about as a journalist as well, depending on how I tailor my communication to a patient who has no real incentive to talk to me. They might respond or they might not. And in the same way, they might sort of respond to a survey question about precision medicine, or they may not. Another theme that I took away from these conversations is that success does not necessarily mean enrollment. And I think we can start thinking about success as being information, reaching out to people that we had not reached before and letting them know that solutions exist. And I think there can be an element of condescension if we assume that, hey, I have this really great precision medicine solution that will work for you, without recognizing that they may not want to medicalize the situation they live in. So these are the kinds of themes that emerge from my conversations with the people that really work on the field. Another theme that came out of talking to all of us is that demonstrating impact back to the community is a really helpful way to get them to come back. And that's one of the reasons I really love this survey that you all are doing here. We're participating and then we can see the results, right? So I spoke to somebody from the National Association for Hispanic Health Alliance, sorry, it's right here, National Alliance for Hispanic Health. And so Edgar told me that that one of the most compelling ways to tell people, to sort of give people their data back is to say, we could not have figured this out without your data. And one of the things I'd love to talk to you all about later is how can journalists do this or communicators do this? What would people sort of out in the community and patients, what would they like to hear from us to incentivize them to participate in things like interviews? So I'd love to, take your thoughts on that. Another thing to consider is sort of how to compensate people for their participation. In journalism, it's not always possible for ethical reasons to reimburse them, but we can think about things like giving them enough time, contacting or sort of meeting them where it's convenient for them, making it possible for them to appear via Zoom versus in person, things like this. The final thing that that a lot of the community members that I talked with, community health workers that I spoke to, told me is that they really would encourage tech companies or sort of research groups who are investigating precision medicine to hire diverse people, and not just community members, not just the people that you send out into the community, but the people that develop the technology. Because if you don't have the people with lived experience actually building it, you're more likely to develop stuff that has biases or that can be misused. So that's sort of what the people I spoke to would like you to hear. So I want to leave you with a couple of asks and then sort of a final message. The first ask is I would love to hear from anybody about how journalists can do a better job engaging patients and communities in our reporting so that we can avoid some of the pitfalls that we've talked about before. The second is if any of you do work in the field, we do need your help in building trust with patients. And so if you have sort of tips and thoughts about how we can do a better job of reaching those patients or which those patients are, I know it's not your job, it's my job, but we do need help sort of understanding what the best practices are. Finally, I want to leave you with this one message that emerged out of my reporting earlier, which is that we all need to be going out into the community more than we do, especially if it's not part of our day-to-day job. And the reason I mention that is I think we make so many assumptions about patients' attitudes or people's attitudes towards technology, and especially underserved patient groups, without actually talking to them about it. And an example that I took away from my reporting is I went out with a street medicine team in LA, and they were handing out these trackers to unhoused patients. And my first instinct was, of course, they don't want that. Like, they would never want that. It's surveillance, especially for people that don't want to be tracked by law enforcement. Why would they ever accept it? And what I found in talking to some of those patients is, yeah, nobody likes surveillance, but tracking, offering these people a tracker meant that somebody could find them in the event of a medical emergency, right? And the need for healthcare sort of overtook their concern about privacy. And those are the kinds of nuances I never would have gotten had I not gone outside and talked to those people directly and asked them open-ended questions. So I encourage all of you to do that in your roles. That's all for me.
Up to down. Invite everyone to come up for our questions and answers session. I finally figured out how to work this technology thing. In the perfect, transparent way with this algorithm, the question is going to be this, online, back. So if you guys want to ask game theory, who gets chosen, go ahead and do that. And while you're thinking about it, I want to open with a question. I really appreciate all of you and what you said. I have so many ideas flowing through my head. But I do want to go back on this focus of hope and dream, right? So the system we have is the system we have. And a lot of times people are like, well, we got to work within that system. I want to dream about what a different system would look like. We can certainly discuss it later this afternoon, because if you don't dream it, it ain't going to happen, right? So what does, and I'll just, this is a saying that people keep saying to me, which I really get it, because I've done community engagement for 25 years. My community people are saying to me, Tung, come on, engagement's 25 years. That's really long. You know, where's prenuptial? Where's the wedding? Okay, so instead of talking about community engagement, can we talk about what it looks like when it's community led? When community is the interventionist, the questioners, and all that. Open to you all.
Y'all know I'm gonna take this one, or at least I'm gonna start, because I think about this all the time. I mean, I work in reproductive health, rights, and justice, and like before a decade ago, everybody and their mother wouldn't say the word doula, and now you got the vice president, the president talk about doulas, right? We got doula, Medicaid reimbursement. You got everybody saying, "Oh, doula's gonna fix maternal morbidity, mortality," right? That's not right, but I'm glad people saying the word doula, right? Okay, so I mean, the way that I think about this is, how radical would it be if somebody used their, let's say, community benefit dollars? By 2025, we are going to become the employer of choice for people who previously used our services. And not only are we going to do that, but like between 25 and 33% of our workforce are going to be people who previously used our services. We would make very different decisions in real time about what the employment trajectory, what the educational trajectory of your workforce is going to look like if that was your goal, right? So for me, I think about this myself, like as a professor, I'm going to replace myself. And not only am I going to replace myself, I'm gonna have like 5 different, BIPOC folks who are going to be in place to be able to say, there are no more onlys where I currently work, right? So to me, the dreaming piece has to really be grounded in what's the focal point of the goal. If it's to have community lead, they got to have jobs. They have to be paid for their work. They have to be in the room, right? I mean, we're taking a big step having community and patient advisory people here in this room, but we also have got to figure out how to crowdsource, this workforce piece. And that's why I'm just such a fangirl, because like Dr. Letitia Montgomery's here, and as a bill, that's it, right? If we know where we're going to place every one of those learners, every one of those students, and we can already identify their leadership potential and give them the tools they need, then we're not sitting here 25 years from now talking about community leadership. They're up here.
All right. I think a lot of time when people talk about hope in the AI worlds, they're looking so far out, and it's about we're all going to live, so much longer and have these rich, beautiful lives. And for me, the over focus on that, and for precision medicine, this kind of far out future where they can solve every single disease and no one's going to experience pain anymore. That's not where, for me, my kind of hopes and dreams lie. I think about how do we make sure that everyone has access to healthcare. So it's kind of putting aside the AI, it's putting aside the precision medicine and thinking, what does it take to, lift up everybody and make sure we have public health, universal healthcare that actually works, so everybody has a chance to access and participate in healthcare. Yeah, I'm there.
I spoke to somebody whose name is Karis Myrick, who's a digital therapeutics researcher, and she mentioned something that I really want to share with you because I've been thinking about it for so long since we talked. But she envisioned this world where precision medicine is not limited to just medicine, and I sort of hinted at that it doesn't necessarily have to be sort of a medical treatment for a condition. But what if we had this world in which like precision sort of therapeutics or treatment or something expanded beyond just medicine, or what we think of as traditional therapeutics to more social services? And I think we are starting to get to that point, but what if we took a much more expansive view on sort of healthcare beyond the medical world and thought about it, how can we bring housing or mental health services outside sort of the healthcare world, things like the social loneliness therapy, things like that, all within this framework? And how can we start expanding beyond just sort of saying, I'll give you a better drug treatment, to something that's a little bit more social focused?
Thank you. Just want to follow up. This is great. I will say that a lot of us who work in social science and population health think that it's not precision medicine, it's actually precision population health. Because if you think about it that way, then precision medicine follows, not the other way around. And I just wrote this grant where I had to look up the data. There's a couple of studies that basically implies that only 20% of our health outcome variation is actually in clinical care. So if you're just focusing on the clinical care setting, you're only focusing on 20%. 50% apparently is from the social determinants of health variation. And that's why I love the workforce diversity model, because the only way that you get both community input in leadership and solve the social determinants problem is to give community of colors, in particular, communities of oppressed people, jobs, good jobs.
I mean, it's like a form of healthcare reparations, right? I mean, I sort of hinted at this in the discussion, but the truth of the matter is, I mean, if we really wanted to retrofit and fix the, flawed Flexner report, why we only have 2% of, Black people being physicians in the United States, we could just make a decision that people who live in close proximity to academic medical centers across the country will have debt-free education for like 50 years. We could decide that. That could be a thing, right? But it's that kind of dream space because, and don't get me wrong, I have fun with ChatGPT. The undergrads and I geek out about it. Like, I love these things. But I also want to be very clear about the fact that they're not going to help with bias, burnout, mistreatment, and a whole variety of other things that are rampant right now in our clinical environments. And if we really want to be able to get at that piece, it's the caring piece. It is the relational piece that is the secret sauce that is going to help us understand how to best use these tools.
That's great, because we should tax all the people monetizing this work and take some of that tax and invest it in education.
Yes.
Is that a solution?
Yes.
All right. Okay. Questions from the audience, starting with this sector. Anybody?
Hi, my name's Rebecca. I'm just an average individual. When I have this tendency, when I start thinking of transparency, trustworthiness, that you're trying to educate a population on not trying to be biased, but you're using words that create their own bias. And when we say there that we're going to be transparent, but we're transparent behind this firewall, you can't know nothing. And it just makes me feel like in the early 90s, 2000s, when corporations tried to get their employees back into the office and they started using this term family. Well, it's a family environment. And now we say, you and me are family. And it's like, well, if Uncle Al doesn't bring turkey every Thanksgiving, are we going to then say, well, we don't need him anymore. Let's look at the bottom line. Oh, let's just cut that person. And you don't think of that when you're thinking of family structure. So when you start talking about words of trustworthiness and family, my brain goes back to when I was 5, when you told me what those things were and I trusted you because you were actually my family. So now you're starting to use that word in corporate culture, but that's not what corporate culture is. You're not my family. You're not looking at what my family's eating. You're looking at what your bottom line is. And when you start thinking about these things when it comes to AI, how are you navigating that? How are we coming up with better terms rather than saying trustworthy? Because trustworthy is a word that I would think that another human would be using, but this is an AI thing. And this is a math thing that you are creating your own bias originally. When you are looking at a problem, you're creating it right now, then and there. Like, how are we not looking at the fact that it's going to be full of bias and be okay with that and live in this gray? Like, we're all looking here where the black and the white is, but no one's living in the gray. Like, how do we affect change? If in a roundabout way, I hope there were questions in there. No, I just felt like I needed to talk about it. So I appreciate everyone listening to my opinion.
I appreciate that because it's questions, comments, suggestions, feedback, and discussion. That's how it works in my universe, right? So you make a very important point, and I want to be really, really clear in terms of my thoughts about it. Because the punchline in all of this is we have a beautiful brain trust in this room. But we actually have to crowdsource this entire conversation to the public and the people that we serve, right? Something that has not been spoken, 2 words that I actually really want to hear spoken in this room. One of them is patriarchy. And the other one is this notion that we have tax-paying employed people who are paying and supporting the scientific enterprise in the United States. They deserve a role in this conversation.
We all don't have to figure this out. We all are not going to figure this out. But we will, to Keith's point, if we get a coalition of the willing to really be able to wrestle with these issues, there are brilliant ideas that live in the head of experts by experience and experts by education. And when you pair all of us in large enough proportions, we can create a future society where the algorithms don't have to reflect the flawed society we currently live in now. I believe that. Does anybody else in this room believe that? Like, okay. So, but we have to be, for me, the trustworthiness piece is being honest about that and telling people and explaining to folks, this is a group effort, right? That's where I think the secret sauce comes in at.
I think this question around the terms meaning different things in different contexts and different communities is really important. I wrote a piece a couple of years ago called "Explainability Won't Save AI" that looked into this problem around that particular term, which obviously was discussed in the last panel in really interesting ways. But the way in which the kind of engineers and the technical community were using the term explainability was just verifying, does my model, is it doing basically what I want it to do? It was completely different from what users wanted from explainability or what policymakers wanted from explainability. And so we did this project of, just actually exploring what those key differences were, providing some light around that, but also suggesting that, if we're going to use that term, we have to be contextual about, who we're talking to, what it means, and how to make it work for more people, while also recognizing it won't in fact solve all of our problems for all the reasons we discussed in panel 1. So just thanks for raising that issue.
Thank you. There's a really common theme about words and what they mean. We explicitly, in planning this, say we want to avoid jargons. And by that, we usually mean acronyms. AI is the only acronym we allow in this meeting. Right? But it's not just about acronym. Explainability is, I don't even know what it means. And it clearly means different things to different people. And in health literacy, we all never like 4-syllable words, right? So if you want to make it understandable, use 1 or 2 syllables. Trust. Okay, this group. Okay, let it.
First of all, thank you, Monica, for the shout out. SF Build is a project that enables full representation in science, and the MPI with me is Tung and Megan Morris. So thank you. And this is related to that. So there was a study done here by the Latino Center of Excellence, and looking at why young folks, transitional age TAY, were not willing to get vaccinated. And what they said is really related here. They said, well, why would we trust the government when we're telling them we need student loan forgiveness? We're telling them we need affordable housing. We're telling them that we need to get jobs when we finish, our college education. I teach at San Francisco State. 6 months after they graduate, 50% are still unemployed. And that's the prestige bias. Because I came from Stanford and Berkeley, and I can tell you that the students at San Francisco State are hella better. But anyway, I've I think convinced Tung of that, and he's working to overcome some of the structural barriers here to hiring San Francisco State students. So the job reparation really is important to me. And what I wanted to ask, in terms of hard to reach populations, which Monica, I think was her, Mohana said, the lab that I lead, we're greater than 50% Latinas, which that's sort of comparable to what the state population is. So it's all good. It's not that I'm doing anything special. It's just passive diffusion as opposed to active transport. So with respect to that, we have no problem reaching Latinas. Like, none at all. I think it would be hard for us to reach white men. It's only 8% on my campus. And so it's, I have many classes with no white men. That would be really hard for me. So how do we lift or get rid of prestige bias, recognize that individuals who have social, communal, linguistic, family capital are important to this enterprise? And that's from the YOSO framework for community cultural wealth, just so it's a CRT approach to lifting the assets of students from marginalized populations.
So I'm a proud MPH graduate from San Francisco State, just so we all clear. And so, you know, go Gators. But I think your point is twofold. First of all, I fangirl Dr. Letty, just so we all clear. Your point, twofold, I think we need to think about, and I think it gets to Mohana's point as well in terms of reaching folks. I don't have any problems reaching minoritized and historically excluded people. They seek me out. So again, if institutionally we decide that we want to become the employer of choice for those individuals, that's a structural fix, not an individual me trying to shift an institution. So again, going back to this context of AI though, I worry that as we start to automate and as things are more amicable or conducive to digital solutions or technological solutions, that we're going to lose the human element. So I will be the person that'll say that anywhere and everywhere, which means we have to crowdsource with folk to figure out ways in which we can engage with them that is meaningful to them. That said, your point around why should we trust the government because we've asked for all these things and we've not got them, that is spot on. I mean, one of the other like inconvenient truths that we also haven't said here today is that, and I tried to get at this by saying that, you know, our immortality is not an option for our species. Without a robust social safety net, we're not going to fix all of the different problems that we have in the health sector or the science community, right? Health and human services go together for a reason, not just because it's a governmental agency, right? I mean, so we're either, and when you look at other comparable countries, whether it's retirement plans or, you know, single payer or whatever it is, womb to tomb data, we are trying to fit a square peg in a round hole. And that is, we are trying to cover, to Tung's point, you know, the 50 to 70% of clinical determinants of health that are not clinical. And so as we start to think about trustworthiness, we also have to start to think about what are the potential intersections, to Mohana's point, that aren't about clinical precision, right? In my field of reproductive health rights and justice, we've got a whole lot of do-it-yourself kind of folks, whether it's home birth midwives to people self-managing their abortions, right? There are things that have been medicalized that within reproduction, one can argue whether or not it's actually a clinical thing or something that should be witnessed by clinical people. So maybe that's more of the innovator mindset that we need to have with young people around, okay, these are things that you have historically wanted to see from your government, legislator, whatever. You've not received those things. Can we disentangle or disassociate some of those things to help you understand why an endeavor like algorithmic justice within precision medicine is going to impact not only your future, but your current capacity to understand your own health information. One of the things we have to do, and this hasn't come up either, we got to update HIPAA. Y'all know that's 25 years old, right? You know it don't cover like this in our Apple Watches, right? That the consumer-driven product. That's a whole other thing that somebody needs to talk about, is the consumer-driven technologies and wearables that folks are using, because that's not covered by HIPAA either. And those are collecting a whole lot of data, and we need to talk about that too.
Yeah, I would just add, you know, sometimes this problem gets simplified as let's improve and increase access to the thing, and then we're going to solve so many of these problems. But when we're talking about experimental technologies, both in the case of cutting edge AI technologies, as well as with some of the precision medicine, kind of more cutting edge treatment side of things, there are real dangers there. There are real risks there that people are experiencing. And so improving access isn't always the actual way to help communities. And so we need to think about that. And in particular, in the AI community, there's this big debate around open source and whether that improving access to foundation models and other kinds of AI models is going to increase the number of people who have a say and a voice in determining these things. And that's often just not how it works. And so you might be improving access in certain kinds of ways and increasing the number of certain kinds of applications, but companies putting out open models like Meta, not actually saying what the data that they trained the system on was. And so it's a certain amount of transparency, but not maybe where it actually matters for understanding the real limitations of that system. And then furthermore, they are they lose the ability to pull that back. So when people say, hey, this is actually putting out biased and toxic and harmful information, there's no way to put those mitigations in place after the fact. And so I think just questioning a little bit whether always increasing access, always moving towards open source isn't necessarily the way to work in everyone's interests.
I don't have much to add except that I was thinking about the term hard to reach populations, and when I was talking to all of us team, they were cautioning against using that term because it should be. I'm now trying to think about it as under-engaged, and so I have not worked hard enough to reach those populations. So that's sort of a language thing I've been thinking about. But the other is we talked a little bit about how to overcome or sort of how to acknowledge sort of the justified medical mistrust or distrust. And at least from the All of Us team, I very much got the sense that it's not to say those things didn't happen. And I know what you're describing is not exactly in that same category, but of medical mistrust, but sort of, acknowledging that, these are things that people have experienced or believe that they will experience, but how can you disentangle them, disentangle what you're taught with precision medicine or something from that without dismissing their concerns? And I know that's something, sort of a communication challenge that the community health workers have to grapple with.
Yeah, working in community, we learn not to use the term hard to reach. We use the term hardly reached. That puts a burden on somebody else, not us, okay?
Yeah.
And then the other thing I would say along that line is when we talk about trust, most of us don't trust someone for one thing. We trust them about everything. So you can't have someone say, trust me on this medical thing, and then screw them on the education thing. I mean, that's just not gonna work. Yes, you got somebody? Okay, online. And then somebody back here.
Hello? Okay, there we go. So we have a question from Ting P online. This is directed to Mohana, but I think you all might have an opinion here. The question specifically is, how would you distinguish community and patient community, with one or the other being maybe more interested in health? But I might back that up and just say, should you distinguish community and patient community?
Yeah, I think so. I think it goes back to that question of sort of are we over medicalizing certain solutions? As a reporter, I try to be more expansive in how I think about sort of health beyond, the health system. And sometimes that can include wellness, but it can also include sort of like social services and things like this. So I do think that, the community impact can be something like, how a building affects things like housing or whatever, but patient impact, sometimes the way we talk about patients sort of restricts us, limits the way we think about the issues to be focused on the medical system. So I do think there is benefit to distinguishing between those two.
Just quickly, it's interesting to think about that relationship in the context of the Precision Medicine Initiative and the All of Us program, because there it's explicitly everyone is part of the community. It's reaching out to everyone to be part of this, grand project together. So I think they're trying to kind of break down that traditional barrier.
I think the dichotomy between patient and community is false, because we have a phrase in repro. People have births, people have abortion. They're the same people. They're just at different time points in their lives, right? And so at some point, I'm a patient, I'm a community member, I'm a researcher. So I would like for us to really wrestle with the language, again, going back to these definitions and language. And I think Keith hit a right tone when he talked this morning about patients and communities. I think we need to learn something from, the pronoun folks and a whole lot of other people, that we're going to have longer lists when we're talking about the foci of the work that we're trying to do. Because if we don't do that, then I think we're going to miss voices that we want to hear from. And I would also push us to use the word communities, because there's not just one community. I mean, there is no monolith, whether it's race, ethnicity, gender, sexual orientation, religion, citizenship, immigration status, whatever it is. There is not one. So I would push people to use the word communities in the plural.
Can I just add one quick thing? Just on the topic of those words, there's a discussion I'm seeing emerging amongst startups and even just companies like larger companies like Amazon about whether we should call patients what we think of as patients consumers or customers. And so I think there's a larger discussion about sort of what the reason I think it's important is because the implication of those words has something to do with our responsibility to fulfill certain needs, right? And if they're the customer, what is it? If it's a patient, what is it? So that's just something else that I've been noticing.
Question over there.
Hi, my name is Adela Lopez Gonzalez, and I'm with the Office of Communications here at UCSF. I thought it was so interesting that Mohana brought up the concept of good participatory clinical practices. This idea that you consult communities before you in your trial design, you consult them before you go in, you consult them during the process, and then you feedback your results, and then continue that consultation as you wrap up or continue that work in the community. When should we be talking about with or consulting with or bringing communities on board in this discussion? Because it seems like there's a lot of frameworks happening currently. And I wonder if you guys had thoughts about when is the appropriate time to do that consultation.
That's tricky because consultation, engagement, there's a whole science behind what the fundamental relationship is when you're talking with communities around science. Right. So for me, I don't even start a grant, a paper, a research project, or even a protocol until I've had a community meeting with the communities that I'm working with. Because for me, the right time always has to be at brain dump idea conceptualization. Because otherwise, the kind of work that I do in particular, I will end up having to retool an entire project because we missed something way upstream. And I don't really like that. So, but I'm also in a position in my career where I can do that. And so working with learners and working with people to understand what those layers are, right? If it's community consultation, you just want them to look at your research protocol that's already been written and they have had no input in it, be prepared for one set of facilitation versus if you're going to co-create that with them. I do this exactly in my classroom as well with my syllabus, right? I work with the students to help them understand how they're going to learn US systems and health policy, because the more buy-in that they have, the more likelihood they're going to proactively engage in that learning. So it's a continuum. And there's no right or wrong answer to this, but there are consequences for when you decide to engage people or not. And that's where time, I think, becomes really important, and honesty.
I think we're at time, right? So I want to close by one thing. I know we're talking about digital and it's zeros and ones, right? And that's just my level of understanding what's going on here. But when it comes to trust, it ain't 0 and 1. There's actually a science of trust. There's a research done on trust. And there's at least 7 different types of trust. And you move along them. You go up, you go down, you go back and forth. You're never in a static position with trust, and you constantly have to demonstrate that you're trustworthy. So this is actually a really important concept. One, I'll make a pitch. So CTSI in particular has a community engagement program. So it would be really hard. We actually say, don't send the trainees, don't send the senior faculty in the community. We can't trust them. They're going to mess it up. So what we do is we have a community engagement program to help them learn how to work with community. We go to the community in their stead, if they're trustworthy, to be their proxy trust. And then we can then do the engagement we need. So it sounds really hard that you have to build trust with these communities that have centuries of oppression and mistrust. And it is hard, but it's not harder than immortality. It's not harder than curing cancer. Okay, we know how to do this. There's a science to doing this. So don't try to reinvent this wheel. Engage us. Thank you.
Thank you.